Cardiovascular disease is one of the leading causes of death for officers around the world. We die from heart attacks more often and younger than the general population. So today, we go into the weeds on all the questions you have about your heart's health with cardiologist Dr. Jon Sheinberg. Stay with us.
You are a warrior.
321 status.
What kind of vehicle is it?
You are the very best your nation has to offer.
911.
Multiple shots fired.
They're asking you to lead.
5. We need a Bearcat.
It's up to us.
So 133. I need somebody that's got a visual on where the shooter is.
You must be sound in mind, body, and spirit.
42, where's the officer down? I have a rescue helicopter that wants to land and help.
This is the podcast that will make you the one.
Copy running eastbound.
The one that will bring everyone back.
Trouble, we have shots fired. Give me backup now.
Because no one else is coming.
We're going to have an officer shot, 100 block of East Street.
Suspect is down.
This is The Squad Room.
Hello, everybody. This is The Squad Room, the podcast about navigating the challenging terrain of our demanding careers as law enforcement professionals. My name is Garrett Tesla. I'm an active duty sergeant for a sheriff's office in Southern California, and I'm here to help you learn tactics and strategies for taking care of yourself, your family, and your community. This episode you're about to listen to is a rebroadcast of a previous episode that I think needs to be heard by as many people as possible. I've selected 10 of my favorite older episodes that have some vital information for you. I often get messages from people asking for a particular guest, and I'd like to say that at least half the time, that person has already been on the show. So I think our show today will have some great information for you that will help you lead a happy, healthy, and successful life filled with purpose. Before we get to the interview, I want to remind you that you can get more information on this episode, including the show notes and links, by going to thesquadroom.net. You can also subscribe on Apple Podcasts, Google Play, Spotify, Stitcher, and all the others, and follow me on Instagram and Twitter at thesquadroom. If you want to find ways how you can help support the show and save yourself a few bucks in the process, I'll explain more of that at the end of the episode, or you can head over to thesquadroom.net/support. I also want to thank our sponsors for this episode, ProForce. If you're in charge of maintaining or replacing your agency's firearms or have a hand in that decision-making process, I want you to pay close attention for just a minute. ProForce is the largest firearms distributor on the West Coast and the only taser distributor in the West. ProForce is known among Southern California and Arizona cops for their great deals on firearms, holsters, and accessories, but what a lot of people don't know is that they also do agency sales, and they are responsible for firearms procurement for some of the largest departments in the United States. Their business is helping agencies replace their aging firearms with modern equipment at the best prices available, and they understand that the momentous challenge that is ahead of many agencies and what that entails. From obtaining quotes to managing budgets and meeting deadlines, it's their goal to help you streamline that entire process to be as effective as you can be. They've tackled massive replacement programs and also have a buyback program for officers that helps them hold on to the firearm that means a lot to them. After 18 years in business, ProForce knows how to help agencies all over the U.S. navigate all the challenges that come with transitioning to a new firearm. And believe me, there are many. If your agencies are at the point where your firearms need to be replaced, and you have a say in that process, you should check out ProForce. I'm confident they'll give you great customer service and a fantastic price on any of the major brands out there. They've helped agencies transition to everything from Smith & Wesson M&P to the Sig Sauer P320, the Glock 17, and every model in between. Also, don't forget about your long guns, because they carry Remington, Colt, and many others. Check them out at proforceonline.com or call their sales department at 1-800-367-5855. Again, that's 1-800-367-5855, or you can email sales@proforceonline.com. They'll hook you up with a free quote, no pressure, no obligation. Just make sure you tell them that you heard about them on the Squad Room. Now, ProForce also has 2 retail locations in Orange County and Prescott, Arizona, so if you're near either, make sure you stop in to see their selection. They've gotten rid of that 2 to 3 hour wait time for firearms purchases, and now they take appointments, and they've got everything you want to go with your brand new gun. Holsters, lights, sights, ammo, and much more. Check out their newest deals at proforceonline.com. And in fact, if you go into the store in Brea and tell the clerk you heard this ad, you'll get 20% off a Streamlight TLR1 pistol light. I use the TLR1 myself, and it's an awesome light, so get 20% off yours in store. Just tell the sales associate the secret password is the Squad Room. All right, so here we are with a rebroadcast of an older episode of the Squad Room with a guest who I think has phenomenal information that's going to help you lead a successful life. Dr. Jon Sheinberg, thank you for joining us on the Squad Room. Thanks for being here all the way from Texas, right?
That's correct.
You're in, I believe, one of my favorite cities. Well, I don't believe it. I know it's one of my favorite cities. And it sounds like it's become a favorite city of half of America these days, but you're near Austin, right?
I am actually in Austin. Yeah.
Okay.
Mm-hmm. Yep.
Way back in my earlier life, I was in the music industry, so I used to come down to South by Southwest every year and was one of those knuckleheads that infiltrated your city for a long weekend.
You wouldn't recognize it now.
He wouldn't recognize me either. But yeah, I hear it's blown up as a city. So I want to jump right into you. I've already explained to everybody who you are.
Okay.
In some sense, I mean, not you as like capital S self, but I mean you are a practicing cardiologist, a board certified cardiologist.
Correct.
And you have that's your day job, which is enough of a job for anybody. But you also have your night job, for lack of a better term. You're a lieutenant.
I am.
And I didn't say this before we jumped on, but you don't have to say the department if you don't want.
No, I'm happy to do it.
Okay.
So I'm a lieutenant at the Cedar Park Police Department, which is a little suburb just outside of Austin. I'm assigned to the Intel unit, which is I'm on the Lone Star Task Force, which is the U.S. Marshals Task Force here in Austin as a task force officer. So Cedar Park carries my commission. I work there a little bit, but most of the police work I do now is with the task force catching fugitives with the Marshal Service.
Catching bad guys.
Catching the worst of the worst.
So I have a lot of questions just about time management, and we'll get to those because I can't wrap my head around how someone does both of those and then still has time for all the things that you have to do to be good at either of those. So We'll jump into those. But, I was in getting ready for this and actually having my own doctor's appointment last week when he was getting on my case about getting in for my physical, got to thinking about this and cardiovascular disease is such a big problem for cops. I mean, this data is a couple years old, but the American Heart Association says that the average age of an officer that has a heart attack is 49 versus a civilian who's 65. And the percentage of heart attacks for officers under the age of 45, that 45% of all heart attacks that occur in law enforcement are for people under the age of 45.
Correct.
And 7% only for civilians. As someone who's only got a few years left before they hit that 45 age, that terrifies me. So why is cardiovascular disease and heart attack specifically, and maybe you can parse the difference between the two, why is that such a big problem for us?
That's a good question, and the answer, unfortunately, is we have no idea. Let me kind of talk about a few things that you mentioned here, and then kind of head into it. So, as a cardiologist and as a police officer, I kind of find myself relatively uniquely positioned to try to take a stab at this. And this question's been asked for years. Why do cops have heart attacks at a rate which is higher than what we see in the civilian sector? And, the interesting thing about this is not only is it known that we have this, but it also has been relatively forgotten and unaddressed. We spend so much time when we talk about officer safety and wellness on body armor policy, reflective vest policy, pursuit policy, all these safety things. We spend an inordinate amount of time on the trauma packs and our quick clot, our tourniquets and whatnot. But the reality is another statistic that you had not hit on is that we're 25 times more likely to die of a heart attack than die at the hands of a suspect from hemorrhagic trauma. So it is a huge problem, and it's been given very low attention because it's just not sexy. It's not, the officers don't go through a class and get a kit and an acronym, and they don't train on it. So it's kind of been sort of not the attention towards this problem has not been what it should be. We don't really know why it's a problem. We actually know that there is a genetic component to heart disease. So there's something about the genes that drive us towards this profession, because we all know people you're born a cop. I mean, you're innately wired. I was first a cop in the 80s before I went to medical school. That is how I am programmed. You're a sheepdog, or you're a wolf. And those of us who are sheepdogs choose this profession, but there's a component to that also causes an increased risk for heart disease. That's hard to define. So we have a genetically increased risk. Then You add to it a profession that is a relatively sedentary profession, which most individuals don't realize that, patrol officer spends most of his or her day in a vehicle. It is a diet of convenience because a lot of our patrol guys, unfortunately, are overly busy and they just eat whenever they have a few free minutes by scarfing down some fast food. It's a shift work cycle. So we know people who do shift work have an increased risk of heart disease. It is the stress that we see in our business is very different than we see in regular individuals who are not in the law enforcement or the other emergency service profession. Everybody that I talk to in their mid-40s and up is stressed out. It is a common problem, but our stress is different. We, and those who do patrol, it is a 98% boredom and then followed by 2% terror. So we have these very interesting cortisol and adrenaline spikes. And something about that combination of the genetics, the sleeping, the diet, the sedentary lifestyle, and the stress pattern puts together an increased risk. Those are things that are hard to tease apart, though. It's hard to control for those things and isolate them.
Well, yeah, and then, humans being humans, there's such a wide variety of other issues you got to kind of parse out, I guess, too. But so, like I said, I recently went to the doctor and I'm doing a lipid panel. I typically do. One of the perks I have is I get free blood tests through my department. So I try to take advantage of that. What if someone is really concerned about this or thinking about this? Health insurance doesn't pay for every cool test out there for someone who is in dire need.
Right.
What are some of the things that an officer can do within maybe the realm of reasonable health insurance or on his own to go ask for?
Right.
To detect this?
That's a great question because ultimately it does fall down to the individual officer to understand what they need to ask for. So I'll answer your question through a different way, sort of a side way, if I may. What we do now, what we understand, and we've my group, we've just published a series of 700 officers who are asymptomatic, and we took these people through a very aggressive screening process, and this is what we've learned from it. We as physicians need to make a determination as to whether or not someone is beginning to form blockage to determine whether or not that person needs to be treated. So irrespective of what cholesterol numbers are, if I have someone who has really high cholesterol and they have no evidence of plaque formation, no evidence of early signs of blockage, that person does not need cholesterol medication outside of barring a really horribly malignant family history or whatnot. On the other side of the coin, if I have someone who has what would used to be considered normal cholesterol and they're beginning to form blockage, that person needs to be treated. So for a moment, let me just say, how do we answer that question? How do we determine whether or not someone is beginning to form blockage? There's 3 tests basically available to do that. One is an ultrasound of the artery of the neck called a CIMT measurement. It's a carotid intima medial thickness test. It's a very quick ultrasound. It measures the thickness of the artery in the neck. That's one reason. That's one way we can determine if you're forming plaque. It's a good test. The problem with that test is it's very dependent on the tech doing it and on the machine. You're measuring pixels. So if you have someone who's got a large neck or you have an older machine or a tech who's not very skilled, the pictures are terrible and they're useless. The second thing we do is we can get what's called a coronary calcium score. This is a very quick scan of the chest. It's done on a CT scanner. It's low-dose radiation, and it looks for the amount of calcification in the arterial wall. You're given a number depending on the aggregate amount of calcium present. 0 meaning there's no plaque. And then, of course, as you move down the line, 1, 10, 100,000, so on and so forth. Those of us who do aggressive preventive maintenance or aggressive preventative cardiology, a calcium score that has any detectable plaque, in other words, a calcium score of 1 or higher, is an indication that you're forming some plaque. And then the third thing, which I believe has the best predictive value, is a blood test called, I'll give you the full words, lipoprotein-associated phospholipase A2. We call it PLA2. Capital P, capital L. P as in Paul, L as in Lima, alpha, and then the number 2, PLA2. It's a marker of inflammation. What that basically tells us, if plaque is beginning to fill the artery, the plaque irritates the artery to a certain extent. That irritation causes an inflammatory response, and it's that inflammation that leads to heart attack. So what we are sort of trying to get out there is every officer should go and ask for a calcium score and a PLA2. The calcium scores are about $50 to $100. The PLA2, the actual cost of that test, is about $15. It is marked up by the labs and whatnot, and you can find it for $100, $199, $75, but these two tests can be gotten for under $100. If either of those tests are abnormal, that would indicate the need for an aggressive cardiac management session.
And so a couple of things I want to clarify. When you say you did an asymptomatic study, asymptomatic for those of us who aren't also doctors and cops means
sorry.
no, it's fine. It's fine. That's my job is to interpret is that these are people who have not shown any indication of any heart disease yet.
Right. So we took people who had no symptoms. If anyone had, whether it was heart disease or not, so we took a group of people who had no history of heart disease and had no symptoms. And we said, look, we're going to check what the percentage of this group of people would be if we decided to put them through this very aggressive screening process. Because if they had shortness of breath or they had a previous diagnosis of heart disease, they were excluded. And we've completed almost 700 patients in this population so far.
Wow. And so I have a weird question about the PLA2 test, but one thing I did when I went down the rabbit hole on this several years ago was reading about the C-reactive protein test and how that is also an inflammation marker test, right? But is very finicky and can be day to day totally different. Is this a test that's pretty standard?
So C-reactive protein is a great test. It's checking for the same thing, but the problem with C-reactive protein, it's nonspecific. So simply meaning if you bang your elbow, if you have arthritis, if your allergies are bothering you, any inflammatory process will raise C-reactive protein, or actually the one we use now is called high-sensitive C-reactive protein. It's very nonspecific. Here, I tell you, here in Austin, it's a fit city, so everybody runs. We also have the worst allergies, so everybody I see has an elevation of C-reactive protein. PLA2 is specific for the coronary or the heart, coronary, what we call the coronary endothelial tissue, which is the blood vessels of the arteries. There's no place else that enzyme lives outside of the coronary arteries. So we see people who have very high C-reactive proteins, but they have normal PLA2s. And those people are not thought to have coronary disease because the PLA2 is normal.
So the calcium score test, that was something in advance of us talking. I did a little, of course, did some research on you and saw that was one of the things that you're advocating for. I asked my general practitioner about it, and he was sort of kind of like, sure, you can. It's not, like you say, it's not expensive. It's not bad. He didn't think that it would show much, though, or not because of my history. In fact, my history would probably indicate that it will show something, but that he didn't find it to be valuable in the diagnosis or in treatment. So one thing I think I run into sometimes, and I've talked to others about this, is that when you have a doctor, specifically a general practitioner, who may not know a lot about our profession or the specific risk factors we deal with, what's the best way to open that dialogue and try and maybe get them to give you some of that more advanced stuff?
You know, that's a good question, and that also relates to anything with a physician, and not only a police officer-physician relationship, but a patient-physician relationship. The patients have to be their own advocates, and it's as if you were going to a restaurant and you're not happy with the food you were served. I mean, you have to be able to say, you know, I know that in my profession I have these risks, and I know there's been some stuff published about these risks. These are the tests that I want, and if the provider is not willing or able to provide them, then I would recommend that individual look for someone who's able to. Now, the problem that we're seeing in this is, especially in some of the advanced cholesterol testing, because the cholesterol testing in and of itself is now extraordinarily complex. A lot of people don't understand it, and the primary doctors have to know everything about everything, and they can't. You know, you see a primary and they had to look at your rash and your backache and your prostate and your blood counts and everything. They can't know everything. Right. So I guess that what I'm trying to get is a really good primary care doctor knows what he or she knows and knows what they don't know. So, and I'm faced with that all the time. People ask me questions and my response is, I have no idea. It's not my field. But the officers who are hearing this, I would sort of implore them that if you are not getting the answers that you feel you should, then, at least for a consultative visit, see somebody else. There are a lot of people out there doing prevention, but not as many as we would like. And it's a fundamental problem in our system because I'm an invasive cardiologist. I make a lot of money when someone comes in and needs a heart cath or has a blockage or whatnot. We don't make that much money in the office seeing patients. So we are unfortunately driven by, we are a procedure-based specialty, and we are driven financially by doing more procedures. So even though the physicians may not be sort of choosing, I'm going to do these procedures unnecessarily, I'm not saying that at all. I'm saying we have a culture in which the preventative stuff has been de-emphasized and the treatment of problems has been emphasized, whereas it's completely backwards. I mean, waiting till someone has a blockage before intervening on it is like waiting till someone has metastatic cancer before giving cancer detection. We want to pick things up early. So the officers have to know, I need a calcium score. I need a PLA2 or phospholipase A2 test. And then I need someone who knows what these things are and can interpret them. And sometimes that requires, you may have the same thing requires shopping around. Same thing if you have a problem with with your water heater. Your regular plumber may not be able to fix it. You need to find someone who knows how to fix it. A leak in the pool, same thing. So it's you have to have I hate this term, but you have to empower your officers to say this is what you need, and I would make sure you find someone who understands that.
That's good advice. And you brought it up, cholesterol. Can you explain the good, the bad? Seems mostly ugly, but there's obviously some good kinds. You said it's getting more complicated. What have we learned?
So let me answer that this way. A regular cholesterol check, which looks at total cholesterol, bad cholesterol, which is LDL, low density cholesterol, good cholesterol, which is HDL, and triglycerides, that's 1975 technology. There's 4 pieces of data on that test. And I will tell you that test is not a good test. It's outdated. A regular cholesterol check is, again, something that we should not be using. The cholesterol checks we do now are we call advanced cholesterol checks. They're cholesterol checks that look not only at the amount of cholesterol, but they look at the cholesterol quality. So, for example, bad cholesterol, LDL cholesterol, it comes in 7 different sizes. Not all LDL cholesterol is bad. Good cholesterol, which is HDL, comes in 5 different sizes. We know there's cholesterol particles that have these little sticky tails on them called LP(a). So our understanding of cholesterol management is changed dramatically. So much so that, as I mentioned earlier, I'm a board-certified cardiologist. There are now board certifications for lipidology, for looking at cholesterol. That's how complex it's got. There's American Board of Clinical Lipidology, which is a board that provides board certification for people who have become experts in cholesterol management. So it's in and of itself its entire own specialty. So you can imagine the intricacies and the biochemistry associated with it. But mastering someone's cholesterol requires a 3-pronged approach, usually. The right lifestyle changes, the right medications if they're needed, and then the right over-the-counter supplements. And if a physician does those type of approaches, we can improve all the numbers. And I'll tell you one last thing. The advanced cholesterol check that I do, I mentioned earlier that a regular cholesterol check has 4 pieces of data. The cholesterol checks that we do in our office have 70 pieces of data. So it's a significantly increased amount of data that's generated, and our ability to detect and treat heart disease at the very early level is just staggering because of the data we're collecting.
That's awesome. I'm gonna have to ask for that.
So there's several companies out there that offer it. They're called advanced lipid testing, and there's Boston Heart Lab is the one I happen to prefer. Then there's Health Diagnostic Labs, or now it's called True Health. There's one called the Cleveland Heart Lab. There's one called Athrotech. But overall, they're all Fords and Chevys. They're called advanced lipid panels.
And so you say there's 4. Your blood has to be outsourced to these people that can do this? This is not something that a normal lab would do?
No. So the blood is drawn and it's shipped up. It's FedExed up to these other labs, and it takes about 2 to 3 weeks to get the results back. So then,
okay, so cholesterol, and you mentioned triglycerides in that, but what's triglycerides, and what's the relationship between triglycerides and cholesterol in this issue?
Triglycerides are the free fatty acids in the blood, and basically triglycerides are they come from dietary carbohydrate consumption. So we look not only at the individual cholesterol particles, but we look at the ratio. We look at the quality of the particles, the quantity of particles, and how they relate to each other. And by looking at by throwing triglycerides into the mix and some we call very low density lipoproteins, we can get information on not only if your body's producing cholesterol, but whether your diet's appropriate or not. And it gives me the ability to look at you and say, okay, Garrett, it looks like you're eating too many carbohydrates. We need to change your diet to this regard. And it gives me the ability to say, okay, you are producing too much cholesterol. You need this medication to prevent that. You're eating poorly. We need to change your eating patterns to look like this. You're creating some inflammation because of all these problems. We need to treat that with this. So it gives me more data that I'm able to look at and come up with a plan. And let me tell you, it's a rather simple treatment plan to get to optimize the numbers.
So triglycerides themselves don't necessarily cause a heart attack or cardiovascular disease? When
they're high in the face of high LDL, makes the LDL worse.
Okay.
But we can see, again, everybody has their own threshold. We see people who have normal cholesterol levels that have heart disease, and we have people who have very high LDL levels who don't have heart disease. So it all depends not only on the amount, but on the quality of the cholesterol. And triglycerides is just one of the components of that.
Okay, so I have a whole host of questions so I'm enjoying this. And so people often, you just mentioned carbs, but fat has typically been associated in the past with the causation for heart disease or cardiovascular disease. And is that still true today, or is it the carbs that you're talking about here?
Phenomenal. These are great questions. So if you go back into the 70s, the McGovern Commission looked at fat, and the whole thought was dietary fat raises LDL, the bad cholesterol. LDL causes heart disease. Therefore, dietary fat causes heart disease. The contrapositive is correct. That's not correct. So what we know about dietary fat, when people eat dietary fat, bad cholesterol goes up. LDL levels go up. But I mentioned earlier that LDL comes in several different sizes. So when someone eats dietary fat, the LDL that are created are large, buoyant, fluffy LDL. Those LDL particles do not cause heart disease. They actually pass right through the blood cell, and they are not absorbed into the blood. They're not absorbed through the blood vessel lining, and they don't cause blockage. So dietary fat does not cause heart disease. What causes heart disease are LDL particles that are small and dense, and those come from dietary carbohydrate consumption, sugar, simple carbohydrates. So the diet that we recommend is very different than the diet that was recommended 30 years ago when these numbers came out. So in the early 1983, the federal government came out with a disastrous food pyramid, which we're all familiar with. It's the food pyramid that had 6 or 7 servings of carbohydrate-laden food on the bottom and then very little oil and fat. And that food pyramid has created the obesity pandemic that we see today. It's created an increased risk of diabetes, and heart disease has not gone down. So we've scrapped that. So the diet we recommend now is more of what we call a Mediterranean diet or a paleo diet, which happens to be the one that I'm which I favor. It's a diet of fresh fruits and vegetables and meat. What we want to eliminate from the diet is not fat, it's processed food. We want to eliminate sugar. We want to eliminate food that is poorly positioned on the glycemic index. So, potatoes, rice, pasta. And if we eliminate those, we actually see a significant reduction in improvement in cholesterol. And we've known this for years, but it's taken a long time. The FDA has finally come back and pulled off their cholesterol recommendations in terms of dietary cholesterol consumption. So there is some questions whether or not saturated fat can contribute to cancers and whatnot, saturated fat being the kind of fat that's found in meat products. But I believe that if those fats are balanced with monounsaturated fats and high levels of the components of fish oil, they don't cause problems. So this is the long-winded answer to your question, that dietary fat, although it had been implicated in the past for heart disease, doesn't cause heart disease. It's the carbs and the sugar that does. It's the Cokes and the Gatorade and, ice cream and candy. That's what causes it.
Hey guys and girls, I'm going to interrupt this episode to talk a little bit more about our sponsor, ProForce. A couple years ago, I was looking online for a new duty gun to replace my aging HK. My agency was taking a long time to close the deal, so I decided to purchase my own Glock Gen 4 G17. I shopped around and found out about Proforce and their insane prices on firearms and accessories, not just from Glock, but from all the major manufacturers, including SIG, Smith & Wesson, Ruger, HK, Colt, Remington, Springfield, and many others. Now, if you're a cop anywhere in Los Angeles or Orange County or even northern San Diego, you already know about Proforce and their amazing deals that they have at their store in Brea. They are only open to first responders, fire, law enforcement, medics, etc., and they are here to serve us. When they reached out to me to talk about working together, I wanted to learn more about them, so I spent a lot of time on the phone with them because though they're known for their great customer service, I just wanted to make sure they were a right fit for this show. Well, Proforce has 2 retail locations, Orange County, California, and Prescott, Arizona. So if you're near either, make sure you stop in and see their selection. They've gotten rid of those 2 to 3 hour wait times that they kind of became famous for, and they've instituted an appointment system that makes your purchase so much faster. And they've got everything you want to go with your brand new gun, holsters, lights, sights, ammo, and more. Check out their newest deals at proforceonline.com. And in fact, if you go into the store in Brea in Orange County, and tell the clerk you heard this ad, you'll get 20% off a Streamlight TLR1 pistol light. I use the TLR1 myself, and it's an awesome light, so get 20% off yours in store. Just tell the sales associate the secret password, the Squadron. All right, back to the episode.
So you just touched on 2 questions I want to clarify. One is on the unsaturated fat. So maybe I can tell this best in a story, and I've told this story before on this podcast, but not to you, of course, that I tried paleo once for 6 weeks. I went super strict, decided to go super strict. I took a blood test the day before I started, and then I took a blood test 6 weeks later.
Okay.
And in the interim, I ate bacon and eggs almost every day.
Okay.
And did all these, did a paleo diet and thought there's no way on earth I'm lowering my cholesterol because I had high cholesterol. I had really high triglycerides. And I just thought it was kind of silly. I was like, I'm all in, but there's no way I'm gonna cause myself a hospital visit at the end of this. And sure enough, after 6 weeks, my cholesterol went down about 90 points, and my triglycerides went down about 150 points.
Yep.
That blew me away. So saturated fat to you, of course, in moderation, but things like red meat, bacon, whole eggs, those aren't a concern to you as a cardiologist if you're taking out the bad stuff of the sugars?
So, okay, I will answer your question definitively.
All right.
Those are not a problem. So a heart-healthy breakfast is bacon and eggs, but not turkey bacon, not processed nitrite full bacon. It's eggs and it's natural bacon. It's the food our grandparents used to eat. It's not a problem. What becomes a problem, I'll give you an example. So we'll have people eating turkey bacon. The problem with turkey bacon is, as you know, by looking at a turkey, no part of a turkey actually looks like that. You peel one piece of turkey bacon off and you look at the piece below it and it looks identical because it's processed, it's injected into a mold, it's dyed. There's the problem. So the problem isn't the naturally occurring fats. The problem is the processing. So people say, I can eat sausage. And my response is, that's great. But, you buy these Jimmy Jones, whatever they are, sausages, and they're full of processed nitrites, and you can't understand half the ingredients. So the benefit, the reason your numbers improved is because you got leaner, your abdominal fat improved, and that is the problem. So the dietary fat consumption, even though you're consuming fat, does not lead to increased levels of high cholesterol. If you were to eat a diet which is low fat and high in carbohydrate, you'd gain weight, you'd have an increased abdominal circumference because you'd have visceral fat, and that's what causes the problems. So the paleo diet, like you said, and I would add one other thing to what your comment was and your sort of interesting experiment you've done. The dietary the dietary fat consumption leans people up, and it is the reduction in carbohydrates, not the increase in fat, that causes the problem. And the only thing that what I would advise after hearing you talk is, we know the more restrictive a diet is, the less sustainable it is. This is why the Atkins diet ultimately fails. So if you had come in to see me and I placed you on a paleo diet, I would have told you, don't be an extremist. The paleo world is like a religion. There's moderates and there's extremists. The extremists will tell you no booze, no dairy, and that's probably the true way of doing it. But the more extreme, the less sustainable. So I tell people, I want you to be 70, 75%. You like whatever your weakness is. You like pizza, you like cookies, that's fine. Have it on Saturday. Take a day a week off, because food's a pleasure of life. We love to eat. And if you are eliminating the things that we enjoy, the sustainability is zero. So we don't look for 100%. I don't look for these hardcore paleo because it doesn't work. We look for a improvement in where you were, and a diet that's not a diet. It's a diet that is a lifestyle change.
And so then back to dietary sugars. So I eat a bagel or something like that. And that, obviously, those carbohydrates get converted to sugar, yes? Mm-hmm. And then how does that process from converting to sugar end up as cholesterol?
So your body has to take they're all carbohydrates. So they're all I answer it this way. They're all molecules of hydrogen and carbon. And the way your body has to transport them and store them. When you think about it, when you have abdominal, or we call adiposity, you have a big belly. That you don't have you eat, if you buy all kinds of M&Ms and candy and soda and you start eating this, you're not going to store sugar cubes in your belly. You convert it into fat, and that has to do with how your body transfers everything. Mm-hmm. So if you can look at these are organic products, and your body has to convert them to transport them and store them. So sugars convert into small, dense LDL particles, and so my recommendation when we hit that is 0. No soda, no juice. People don't realize that a glass of orange juice, even if it's fresh squeezed orange juice, has more sugar than a can of Coke. So we can eat the fruit, because when you consume a piece of fruit, you're getting all the soluble and insoluble fiber in the fruit, and that mitigates or reduces your ability to absorb the spiking of the glucose consumption and your insulin spike. So we recommend no sugar, very low carbs, as low as possible. Now, we don't need to put people into. You remember the old Atkins diet? We used to put people into ketosis. We don't need that. I don't believe that's healthy. Mm-hmm. But if you reduce the carbohydrate consumption, we see significant improvements, just like you described.
Okay, so thank you for explaining that. So, because my question is about the sugars relates to what my next question is, and you kind of mentioned it with the abdominal fat. But given the shift work and just the line of work that we're both in too, is there a relationship between heart disease and heart attacks and diabetes?
Without question.
Okay, can you explain some of that?
So, matter of fact, I was just talking about this. There's a very simple, it's sort of an oversimplification, but there's a very simple way of kind of understanding this. When someone has diabetes or and I got to mention that the term diabetes is sort of misused, because people say, oh, I'm pre-diabetes, or I have diabetes, or I really don't have diabetes because I'm not taking insulin, I'm on medicine. So we tend to use the word, hyperglycemia, too much sugar in the blood. If we took a fasting sugar on someone, it should be in the 90s or lower. There's several ways of measuring diabetes and coming up with an official endocrinological diagnosis of diabetes. But the reality is, when you have too much sugar in your system, the best way to think of it is these sugars act like little shards of glass. The sugar crystals actually damage the blood vessel walls. So if I were seeing a patient who is a diabetic, we consider that person to have what we call a coronary risk equivalent. We treat a diabetic as aggressively as someone who's come back from bypass surgery, because diabetes, the sugar in the blood, damages blood vessel. So diabetes is a definitive risk for coronary disease, and like I said, we call it a coronary risk equivalent.
It seems like a lot of the discussion that is coming out now, I just attended Dr. Kevin Gilmartin's class. I don't know if you've ever seen him speak, but he's a psychologist, I believe. But he talks a lot about the physical issues. And Dr. Kirk Parsley is another pro-law enforcement medicine. He's a sleep specialist, but he also talks about diabetes in relationship to sleep. But it seems like what a perfect storm of issues that we are faced with when you deal with it. Like you say, a diet of convenience, and if you don't attack your cardiovascular disease, you're also opening yourself up for diabetes. And I know that cops are pre-diabetic. In general, we are often pre-diabetic, I guess. Or I learned this recently. They call type 2 diabetes is sometimes called the policeman's disease.
Yeah, it's rampant. We just did a study on a local department with about 100 officers in it. 66% of those officers had preclinical heart disease, so blockages before they became clinically manifest, but 37% had undiagnosed diabetes or prediabetes.
Why is it undiagnosed? Just because they didn't go get a blood test, or we weren't looking at the right thing?
Because they hadn't gotten, what happens when you're a 30 to 45-year-old guy? A lot of us feel fine. We don't go to the doctor. It's an endemic problem. Now, sometimes you have to go for your, you got to get this signed off and whatnot. But let's take out cops for a moment. Males our age, and men between the ages of 25 and 40, typically don't go to the doctor that often. So these people feel well, they have no symptoms, and these things are not causing problems at the moment. They'll cause problems downstream. So these people had no idea, or they had been told, I was told by my doctor a few months ago or a year ago that I was heading in that direction. But we look at this, and now in my practice, and when I talk to my patients and my officers, I tell them I don't use the word pre-diabetes or pre-hypertension. It's like saying, either you have it or you don't have it. It may be diabetes that is very, very mild and can be treated with just watching carbohydrates. But when we start saying pre, it's a very gray area, and depending on who you talk to, that pre-level stops at different areas. So I tend to say, look, you have hyperglycemia, you have too much sugar in your blood.
Mm-hmm. So you mentioned the diet that you would recommend for minimizing or mitigating this, and then you mentioned the three things: diet, medication, and supplements. Well, correct. Medication is up to you. Diet is up to us. Supplements might also be up to us. What supplements do you recommend that we work on?
Okay, so I will make sure I make this clear, because I travel all over the country and talk to different police departments as we start setting up, as a big try to set up wellness programs. And I always have to emphasize that I do not recommend sort of blind use of supplements. So going to GNC or what other vitamins or whatever and getting a bag full of supplements thinking it's going to have a positive impact has never been shown to do anything. However, if we tease out some information on these advanced cholesterol checks, we can use these supplements in a targeted fashion. So, for example, we measure fish oil levels. We measure EPA and DHA levels. And there are studies that show us that if you have the adequate amount of EPA, which is one of the components of fish oil, that reduces heart disease. If there's inflammation, we know EPA reduces heart disease. We measure vitamin D levels because we see people who have adequate levels of vitamin D sleep better. They also have less inflammation. We measure something called homocysteine, which is an amino acid, and if it builds up in our system, it tells us that we have a difficult time metabolizing folate or vitamin B9, and we supplement with that. So I guess what I'm trying to get at is I would guide the use of supplements pending the testing that's come out.
So so you just said it, but this is not something where, I try to take fish oil as best I can when I remember it because I have low HDL, and it was recommended that would help bring up my levels a little bit, but not something that I would run out to. And I do vitamin D as well on the sleep end. I didn't realize it had a connection to anything heart related, but I found that vitamin D and magnesium, and then even throwing in GABA, I sleep a lot better. Mm-hmm. Because you're not the sleep guy, but I have a whole host of sleep shift work, sleep disorder, sleep apnea, other issues. So really you would recommend the blood tests first and then kind of filling in the gaps with the supplements from there.
So there's two problems with supplements. First off, that's a completely it's a $15 billion a year industry that's got no regulatory oversight. So the claims that are made are a lot of times not substantiated. And you can get products that have no active ingredient in it because they're not regulated. So there's plenty of things written up. For example, Consumer Reports will pull vitamin C off the shelf, and there's no detectable vitamin C in the capsules. And the New York Attorney General is suing GNC because they did a whole bunch of testing, and a lot of their products have no active ingredients in them. So you have to make sure you have a product that someone knows it does something. It's not just anecdotal, and you have to get a product that's a good quality product. Otherwise, you may end up spending your money getting nothing.
So do you have a brand that you go to for some of these yourself?
I do. And I will, again, this is, full disclosure, I have no affiliation with these companies in any way. There's three brands that we use. One is called Metagenics, one is called Orthomolecular, and one is called Zymogen. And let me put this out there for you. We have if I may,
sure.
we have a nonprofit website that helps facilitate some of the cardiac screening. It's the Public Safety Cardiac Foundation, which is publicsafetyheart.org. The Public Safety Cardiac Foundation actually has an agreement with Metagenics, and on there under the donate page, there's actually a link that you can click on and go right to the Metagenics website and order over-the-counter supplements. They're not marked up, and the profit that's generated from the sales of those go back to the nonprofit. So
awesome.
The nonprofit helps cops and firefighters and EMS workers get screened for cardiac disease. We send a few cops to EMT school every year, so we're really involved in trying to keep cops healthy. But the Metagenics product is what I believe to be the best stuff on the market, and these are products that are they're sold in doctors' offices. A lot of doctors will buy this stuff, mark it up, and then sell it at the front desk for a profit. We're able to get it through our nonprofit at cost. There's a small margin that's built into each purchase, and all that goes to the nonprofit.
PublicSafetyHeart.org. And I'll put show notes. I'll put the links in the show notes for this episode too, so people can go to this episode on the squadroom.net and just find all of this information you're giving out too. Because that's one thing I always struggle with is you buy I'm into the CrossFit world, right? And I drank that Kool-Aid. And even some of the higher end, quote unquote, high end supplements, the grass fed, free range, cage free supplement stuff has been found to be relatively benign.
Right.
And you're paying through the nose or through the teeth for some of those things too.
Right.
So, okay. So we touched on a little bit, but sleep, we talked about it, kind of in relation to diabetes, and it seems to be well connected to diabetes, but how is it connected, or is it connected at all to cardiovascular disease?
So they're all interconnected. So let me tell you, there's actually one published study on obese Taiwanese police officers. And they looked at these people, and what they found is a correlation between these officers who slept less than 5 hours a night and abdominal obesity. So we know that increased abdominal circumference or abdominal obesity or adiposity, if you have a big belly, that is in and of itself a risk for heart disease. Those people tend to have what we call the metabolic syndrome, which is low good cholesterol, high triglycerides, diabetes, poor cholesterol quality, and those are the setups for heart disease. So the risk of poor sleeping gives an increased risk of obesity, and the increased risk of obesity causes hypertension, diabetes, coronary disease, sleep apnea, and sleep apnea comes back again. Now that causes more heart disease. So it's a vicious circle, but the sleeping is one of the components of that.
So here's a question for you then, and this show has always been kind of myself and my experience and my journey to try and get fit. So I use myself as the guinea pig for this show a lot and talk about my challenges and my struggles. So this isn't a new thing to listeners. So I'm going to give you my kind of current scenario or where I was recently, right? So because I have a question about metabolic syndrome, because it seems to be a buzzword. And then you talk to some medical professionals who just say it's kind of a hodgepodge of symptoms that doesn't really have any effect. So, okay, so let's see. Cholesterol recently was, I think, a total of 230. Triglycerides were 325, which I know is high, very high. Like I said, sleep apnea and shift work sleep disorder. And I have, I would say, significant difficulty getting rid of that abdominal fat. I'm pretty well structured everywhere else, but I can't get it out. and granted, diet could be a lot cleaner than it is, but like you said, I try to work about a 75-25, clean diet. So that's just, I don't expect you to diagnose me, but the setup there is I've asked about metabolic syndrome in the past, and it seems like because I have decent sugar levels in my blood, that they don't think that I have any issues with metabolic syndrome.
So if I can interrupt you there. So I think what's happened is you have not had enough testing done. So if you had one of these advanced tests, they pull out a couple different things. So we look at a bunch of different markers to help you sort of further determine that. So one would be not only HDL, but HDL quality. The fact that your triglycerides are high is in and of itself an indicator that there's probably a dietary carbohydrate issue. We look at the small, dense cholesterol particles. And then when we look at glucose markers, we don't just look at the fasting glucose or hemoglobin A1C, which is a marker for how sugars have been over the last 3 months. We actually look at insulin resistance and insulin levels. So we can look at someone, and for example, let's say we have someone who, and this happens all the time, I'll have someone who comes in who looks at their numbers, and their hemoglobin A1C, or we call the glycosylate hemoglobin, is normal. And that will say, okay, your sugars are fine, but you look at that person's insulin levels, and the normal insulin level should be up to 15. This is 40. So what's happening in that person is their pancreas is cranking out more than twice the amount of insulin it should to meet that person's demands. And that's temporizing. You can't do that forever. It's like the equivalent of driving up a hill and you got your foot floored on the throttle. It's on the base, it's all the way down, and you're able to maintain the speed, but the engine's working harder. Mm-hmm. So eventually that's not sustainable. So again, I without seeing a full metabolic path, full metabolic workup, it sounds like it's a carbohydrate issue. And the other thing is understand that the listeners should understand that I can't look at someone and say, you need to eat this amount of carbohydrates, because everybody's different. I have patients who eat like garbage and their numbers are beautiful. And I have other people who eat clean and have one slice of bread. I have one lady today I saw, she eats some quinoa in the morning and her numbers she's pre-diabetic. So everybody is different. So to kind of group everyone together and say, you should eat 20 to 30 grams of carbohydrates, that worked for a lot of people, but some people can eat 3 or 4 times that much and still have the same numbers. So it's very individualized. But my question to you is, when you did your intense paleo for the month or two that you did it, did you lose abdominal weight? Did that make a difference? Because that seems like the answer. You may need to be a little bit more hardcore just in the way your body is.
Yeah, no, I certainly lost a lot of that weight. And just like you said, it was just a matter of sustainability
right.
at 100% strict. But it's something I know I need to go back to myself. And it's hard to, I've talked about this before too, but having a podcast about health and fitness for law enforcement officers, knowing that I still have a lot of work to do, which is actually just the whole point of the show, I guess, is that, there's other people out there and there's other people. And the reason I have you on right now is because I want to learn this information and then share it with other people who need the same information and just don't have a microphone at home. So this is all good to kind of ingest. So obviously diet, we've talked about diet, exercise is the other component of this, I would imagine, right? So what is your recommendation or your general inclination in terms of what kind of exercise, how much per day or per week would you advocate for? And is there a specific type of exercise, cardio versus weightlifting versus interval training versus spin class or soul yoga, whatever?
So let me answer that first by saying there's no data that's ever been generated that shows that exercise causes weight loss. So for people who are wanting to begin an exercise program to lose weight, it has to really be understood that weight loss is a diet problem. A matter of fact, it's been proven time and time again, if you take a group of people and you subject them to a change in exercise or calorie expenditure and you don't change their diet, they don't lose very much weight. In fact, a lot of those people, if you leave their diets alone, they actually gain weight because they're hungrier, because they're exercising more. So people who say, oh, when I exercise, I lose weight, there's a component to that which people don't realize, and that is if you're going to go run 5 miles, you have a sort of a better fit mindset. You're less likely to go to McDonald's or, and get burgers and fries. So exercise is a huge component of cardiac and health and wellness, but it's not a weight loss answer. So you get the nutritional component done, which we talked about, the paleo type diet. In terms of exercise, the benefits that we see go from becoming sedentary to being active. So let me take off the cop hat for a second. I tell people you need to be exercising 3 or 4 times a week, 45 minutes at a time of brisk aerobic exercise. And then the question is, well, what do I get my heart rate to? And then my response to that is, don't wear a heart rate monitor. Exercise until you can barely carry on a conversation. If you're walking and you're chatting with the person next to you, it's not hard enough. If you're running so hard you can't talk, it's too hard. You should exercise until you're just barely able to conversate with the person next to you. That's great, and then maintain that. The other thing we do is intervals, and it doesn't matter if it's on the bike, on the road, because here in Texas, our physical fitness standard for a lot of police departments has come down to a Concept 2 rowing machine. So we do a lot of rowing down here now based on our Texas Department of Public Safety validation of that device as a sort of a job-related performance measurement. But so we do I recommend these things called, they're intervals. They're 30, 20, 10s. If you're on the elliptical, on a treadmill, on a rowing machine, you do 30 seconds, casual or easy, 20 seconds hard, and then 10 seconds burn it as hard as you can. That's a minute. And then you reset and you do another another rep of that 30, 20, 10. You do 5 of those. You take a 2-minute break, 5 of those, 2-minute break, and then you do that 3 to 5 times. It is a tremendous workout. And there's very good data to show that actually improves fitness, weight loss, everything over all the other types of workouts. So we know interval workout is probably the best kind to do.
So I want to clarify this because at this exact moment, as you might see I have a cast on my hand from a foot chase that ended with a pop. And I'm on the elliptical because that's about all I got. That's about it's all cardio these days. So I'm going crazy with the cardio, with sitting on the elliptical machine, and I'm doing kind of a longer version of this, I guess, over maybe a minute of graduated from, on a scale of 1 to 10, maybe 5, 6, 7, 8, 5, 6, 7, 8. And then eventually after the fourth one, getting 5, 6, 7, 8, 9, 10 and going all out and then resting. This is much shorter.
It is. But there's actually good medical literature to support the 30, 20, 10, or sometimes people call it 10, 20, 30. And there's even apps you can get for your phone that when you're listening to your music will ping at 30 seconds, 20 seconds, and 10 seconds and keep track of your reps. So 30, 20, 10, 30 seconds easy, 20 seconds strenuous, 10 seconds burn, and then go back to the cycle again.
And do that 5 times. And then after those 5 times, you take a 2-minute break and then do that a total of 3 to 5 times.
3 to 5 times.
I'm on my way to the gym after this. I'll give it a shot.
It's I'm going to tell you, you need to let me know how it goes. It is deceptively simple, but it is, you'll be surprised, and you'll get more out of a 4 cycles of that than you would if you went out and you ran for 40 minutes.
Interesting. Okay. So I want to jump more into you with some of these because cardiologist, who you do, like you said, invasive therapy, and police officer. And I didn't know you were a police officer actually before. Yeah. You were a physician. Both of those jobs are known for bad sleep or poor sleep and fatigue, having to work through fatigue. Mm-hmm. I suspect you have a life of some sort outside of these two things. How do you manage all of those things? And I guess another question is why? But I'm just curious what your routine is like, that with the knowledge you have, how do you implement that to maintain your own health, given what you know about both of these issues?
So I eat paleo, so I eat clean. I hit the gym 4 or 5 times a week, and I'll do anything from, I'll have a couple slow days, or I'll do 1 or 2 days a week of just 1 hour on either on a treadmill or on a 48. So my knees are starting to go, but on an elliptical. And again, here in Texas, we validated this torture device called the Concept 2 rower. And so I'll row a few days a week, and I'll do the 30, 20, 10. So, and I'll do CrossFit too. So I'll mix up the workout. So I hit it every day. And I can't, and literally, and not that I need the fitness when I work as a cop, but also, quite frankly, if I'm sitting in front of a patient and I'm not fit, I lose all my credibility. So I have to sit in front of you. If I tell you, look, you can't eat that stuff, you've got to get to the gym. And then people say, I don't have time. I go, you want to hear about time? I have 2 jobs, 3 kids, and there's always time. You just have to prioritize. So my schedule is interesting. I work mostly as a cop. I have 1 full day a week I take off and work for the police department, and a few half days. And, I don't do patrol anymore, but I do warrant service with the marshal service. And that usually occurs at varying times. And my coworkers, they'll sit on houses and follow stuff. And before we take a hit, I'm able to go in. So, I'm able to kind of pick and choose the things that I want. And I also spend a fair amount of time doing exactly what we're doing today, is trying to get the word out and go into different departments. My skill set is not best used doing traffic stops. Right. My skill set is keeping our officers healthy and alive, and that includes doing making sure they have the right combat casualty care training, make sure they have the right IFACs and the right tourniquets, make sure that they have all the preventative stuff that they need to keep them healthy, and make sure that they get in when there's a problem. So it's equivalent for, when I was in the military, there's, every military organization that has a group of people that are perceived to be at increased risk, they have, battalion surgeons and flight surgeons and ship surgeons. I'm under the impression that every large police department or every group of cops should have a physician associated. The problem is cops don't like to talk to anybody who's not a cop. So in the state of Texas, there's about 8 of us who are sworn officers and doctors. And nationwide, there's probably 50. So it's not a tremendous amount of us, but we're out there. There are a lot of doctors that are also willing to get involved that are not sworn, but they have a harder time breaking through to the barriers. And I stand up in front of a group of cops and I have a white coat on, so to speak. No buy-in. No one listens. But if I stand up there with my gun and a badge on my belt, all of a sudden I have everybody's attention, even though the message doesn't change. So, but I'll take a typical week will be, a few days in the office, a day with the Marshal Service, and then hitting warrants either in the morning or at night. And but you know what? I love it, and it's been part of my life for 25 years. That I can't give it up. It's part of who I am.
Have you found any routines or even phone apps or anything like that helps you regulate your day? I've found that for me, again, something I talk about quite a bit, cognitive fatigue is a big deal. And if I can lessen the amount of decisions I have to make throughout the day, it makes it easier to get through the day. Do you have a routine in the morning, or do you have things that you have set in place that help you get to help you do that?
Nothing sort of definitive, such as an app or a scheduling program. But, my day is, especially once I get here to the office, it's so regimented in terms of, every 5 minutes is sort of accounted for. But, I'll cut out early some days to hit the gym and do what I need to do. I'll get to the gym early some days. So I look at it and make it a priority. And the other thing I do is I plan my meals. I don't just show up somewhere with no food. I usually bring lunch. If not only to work, but if I'm going to go out and do police work, I'll make sure that we have, I pack my food. So I'm not scrambling to go to Wendy's at 2:00 in the afternoon because I haven't eaten all day. I'll bring a bunch of snacks and I'll bring the right food so I don't put myself in that position. And that actually carries along that if I'm going out for dinner, and this is just a personal thing, I kind of know what I'm going to eat before I get there. So I don't look through the menu and go, and then the waiter comes over and you're kind of rushed. I know what I'm going to eat. And if it's very easy to pre-plan. And if you do, you end up choosing better foods. So we pre-plan the meals. I make the time. And I won't kid you, it's busy. I'll work all day and get notice at, 4:00 that we're going to serve a warrant. And I'll take off my scrubs and I'll put on my vest and my tack stuff and go out and do the warrant. And but I enjoy it, and it's not work. It's fun. It's like I said, as you've been doing this for years, it's who you are. It's part of what you do. And it's hard to define. For a lot of people don't understand it. Why do you want to do that? Wouldn't you rather go do this and do that? And my response is, no, I love these guys. The guys that I work with, that's that kind of relationship and camaraderie doesn't exist on the outside. It's very valuable for those of us who've served in the military or work on police departments. That friendship and bonds that occur, that doesn't happen. And most people don't get that.
Right.
And so I'm very fortunate, like I said, that I'm able to participate in both worlds.
That's awesome. I have one last question if you have time.
Yeah, absolutely.
I talk a lot about the importance of having a team. And you're just talking about how law enforcement is a team, and that's an environment. But I guess in the sense of team of people who are there to either support you or play a role in your health or your fitness or your growth as an individual or as a leader. Often say that you're the average of the 5 people closest to you. That kind of concept. So I talk about how I'm building my team and how some of those people are on my team, and there's coaches on that team too. Do you have who would you say, given your position or given your perspective, what kind of people do cops need to have on their team? And do you have any coaches?
Ooh, that's a really good question. That's a deep question. So, I think let me answer that in 2 parts. In terms of what people, the cops need on their team. I mean, first off, there's a tremendous amount of peer support that's there, but it's necessary. And that also manifests in our humor, because we joke about the most morbid things, because if you can't joke about it, it's really hard to deal with. And you know exactly what I'm talking about without having to go into it.
Sure.
But we see horrible things and, they end up making jokes, because otherwise, if you don't, it's almost we see the worst of the worst. And if you don't find humor in it, it's not that humor is a tremendous coping mechanism. So my advice in that regard is, people who are if you ask me how I would say a young officer coming out looking to kind of enter this field, who should they follow and mentor, even unofficially, are the people who are not bitter, the people who've gone through this. You know them as well as I do, people who are punching the clock, ready to get out. They sense the department screwed them over. They're going to do the little amount as they possibly can. That's probably the people to avoid. But there's good quality people who've developed very good coping skills, support skills, and those are the people that I use. I would recommend, and that can be from the chief's office all the way down to the senior police officer who's on the street for 25 years. For myself personally, it's interesting. I really never thought about it that way, but both of my parents are deceased, but they were huge influences in my life. My family acts that way, and I have been fortunate enough to have very good friends both in the physician sector and in the police sector who have set examples for me to follow. So I wish I don't have one person in particular, but I like to look at a group of people that help me become where I am.
I think I can't believe I'm about to quote Oprah, right? What it takes a village. My wife is obviously influencing me.
Sure.
Dr. Jon Sheinberg, board certified cardiologist, Cedar Park Police Department, special agent with the U.S. Marshals, or
a special deputy, U.S.
special deputy
officer.
That's a lot of titles for one guy. Thanks for being with us on the show. PublicSafetyHeart.org is your organization. Twitter, Instagram, you ever there? Or are you just too busy running and kicking in doors and opening hearts?
That's on the list of things, but no, we do not have a Facebook, a Twitter, or an Instagram as of yet.
Well, maybe we can connect up, and I'll help you create the accounts and all that for the future. Thanks for being with us today.
Thank you.
If you like what you heard today and you got something out of this conversation, please consider leaving a review on the podcast player of your choice. Second, share this episode or any other episode you loved with people you know who need to hear it. You can share episodes right from our webpage at thesquadroom.net and from most podcast players. If you heard something today you know a friend or loved one needs to hear, please tell them about the show. And you can email this episode even directly to them. If you want to know how you can support the show, there's a few ways to do that. If you head over to thesquadroom.net/support, you will see a few ways that you can help the show and save a few bucks. These are all what's known as affiliate links, so for any purchase you make there, the podcast receives some compensation. It's important to know that it doesn't change the price for you. The first, biggest, and easiest way to support the show is when you do your Amazon shopping. Before you head to Amazon to purchase anything, please go to thesquadroom.net/Amazon. Just click the Amazon button on that page and carry on with your shopping. Amazon will see that you came to them through our site, and it really helps support the show. There are also deals on there like 10% off Onnit supplements by going to onnit.com/squadroom, Ranger Up clothing, and Hardhead Veterans ballistic helmets. If you want to try out an audiobook, you can get a free month subscription to Audible and a free audiobook of your choice by going to audibletrial.com/thesquadroom. Again, that easy place to find all of these is at thesquadroom.net/support. Lastly, I want to thank our sponsors again, ProForce, so check them out at proforceonline.com. And until next time, take care of each other and stay safe.